So good morning, everyone, and I think we'll start with the next instruction course. That is, can you give me the first slide, please? The next we are discussing is how to prevent trabeculectomy failures. So trabeculectomy still remains a most frequently done glaucoma surgery to control intraocular pressure. And even though a lot of happening in glaucoma surgical space, but the trabeculectomy is still one procedure which we all need to know, learn, and also deal with if there's any problem. So in this course, we are basically answering two questions: the why trabeculectomy fails in the first place, and what we can do to keep them functioning if the failure happens or if the failure is expected. So this is basically the scope of today's seminar is. So we have a number of speakers. We will cover the risk factors for the bladder failure. Dr. Purvi, he's not able to come, so I'll cover in my talk. So I'll combine sort of the first two talks. And then we have the pathophysiology. That's very important to understand, because whatever actions you take in the post-operative period, if you understand the pathophysiology of the failure, you would be better equipped to deal with that. Then we'll have, if the trabeculectomy is kind of a failing, then how do we resurrect it? And Dr. Sushmita will do how we can do it from Aventurno, and needling procedure by Dr. Faisal. And then I'll also do a little bit of the bleb revisions, sort of full surgical revision, how we can do it in a limited fashion so that you have lesser surgical time, lesser complications. And we'll be happy to answer your questions in between or at the end, whenever you feel like. So we'll go to the why TRAVS fails. So can we load the other one? This hyperlinked actually, but hyperlink is not working here. So I'll have to depend on the oops. Okay. All right. So why TRAVS fail? Basically, there are a number of risk factors for failure, and that's what we're going to look at. The pathophysiology and how to identify the blebs that are failing is very important to identify which bleb is going to fail, and so that you can take remedial measures. The glaucoma surgery principles you very well know. We are basically diverting the aqueous from the anterior chamber to the subtenon or subconjunctival space. And because, we hope that in the subconjunctival space, the aqueous will be absorbed and it will flow out. So there's a lower pressure gradient compartment. So because the AC, the pressure is high, it goes into the lower pressure gradient compartment and it gets absorbed from there. But if for some reason the aqueous is not getting absorbed from there, then the pressure gradient will be abolished and there will not be any filtration. And that is what happens actually when glaucoma fails. So normally, because we have done surgery, we had breached the integrity of the tissue, so normal healing is required. So that will prevent the blood leaks and complications. But sometimes there's excessive healing happens, there's fibrosis, and that actually prevents the filtration from happening, and that is not good for our cause. So good blebs are basically, it's hard to define what is a good bleb, but any bleb which serves your purpose, that means there's a bleb and it is controlling the intraocular pressure would be a good bleb, and which is not very thin cystic. But generally speaking, they are kind of low-lying blebs, diffuse, normal vascularity, I would say, and generally they have microcysts on slit lamp and not very close to the limbus or overriding on the cornea. But unfortunately, many blebs fail and they can look very, very different. Like you have a totally scarred bleb, that looks like there's no bleb at all there. They have cyst formation, then a lot of vascularization. Sometimes the bleb gets very localized. The fluid is coming out, but it's not actually getting drained, and sometimes they become very dysmorphic. So there are a number of ways the bleb can actually fail. But overall, you can see the trabeculectomy failure rate is quite significant, 30 to 50%. Depending on the clinical situation in 3 to 5 years. And a number of factors, so we'll come to the factors, how the blebs fail. So factors could be in the preoperative workup, postoperative, or intraoperative. And we actually have to take care of all these factors. And preoperative selection is very important. And there are a number of, you're all well aware of these actually. Young age, black ethnicity, history of previous surgery or cataract surgery, combined surgery, uncontrolled IAP before surgery. Other conditions like uveitis, diabetes, trauma, poor ocular surface, patients on prolonged anti-glaucoma therapy and the lid inflammations, they're all risk factors for failure. So preoperatively, I think they should be treated as far as possible. And intraoperatively, if there's excessive bleeding, excessive cauterization, or there's other complication, flap-related complication that can also, contribute towards failure. And then in the post-operative period, things could be like bleb leak, shallow ACs, choroidals, high IOP, and additional surgeries if are required to maintain the integrity of the eye. Again, that will all contribute towards failure. So all these conditions should be handled pre-operatively or during surgery or in the post-operative period. So, bit of the blood physiology, basically when you're doing glaucoma surgery, there are three things. So we are inducing trauma, surgical trauma. There's the aqueous humor which is flowing into the tissue. There may be a foreign body in the form of some suture or some stent. If you are doing a stent surgery, then that would be a large foreign body there. And ultimately what happens is how the subconjunctival tissue interacts to all these three factors. That's what is going to determine the results. Now, if you have just a conjunctival wound, normally it heals very fast. You do pterygium surgery or you do some conjunctival, graft or something, and the conjunctiva actually heals very quickly. Within 7 to 14 days, the wound actually completely heals. But once there is an aqueous getting into the space, it doesn't heal. It takes very long. So the presence of aqueous is very important, and because it has pro-inflammatory cytokines due to the breakdown of the blood-retinal barrier, and they keep the inflammation and keep the wound healing process going for a longer time. And also, flow of aqueous is also known to cause some mechanical stress or the fluid-related stress in the tissue, which activates fibroblast and converts into myofibroblast, and they actually proliferate, and they also lead to excessive wound healing. And then with subconjunctival tissue, the interaction with these events, they're more prone to develop again those pro-inflammatory or pro-fibrotic chemicals in that space, which will lead to failure. And also something which we usually don't keep in consideration, which is very important. Also, what are we doing to the blood vessels? Because we are smearing the blood vessels, we are cauterizing them, we are actually physically removing blood vessels in that space to get a good surgical exposure, but that actually leads to more hypoxia and more hypoxia related events which follow. And also the lymphatics. Lymphatics we normally don't put in the equation, but they are very important because they also help drain, keep the subconjunctival space dry and drain the fluid away from it. So there are a number of factors which are there actually. And if you look at a normal wound healing, so normal wound healing goes through different phases. The coagulative phase that kicks in immediately after the surgery, then you have inflammatory phase, proliferative, and by 2 weeks actually the proliferative phase should start waning off. But in glaucoma surgery, it doesn't go off and it lasts for 2 to 3 weeks and sometimes even longer. So the longer the proliferative and longer the inflammatory phase lasts, the more is going to the scar formation. And in glaucoma surgery, the presence of aqueous delays the remodeling phase. So that's why we have more fibrosis tissue. So wound modulation phase or the remodeling phase is when the excessive scar tissue is actually removed. So there's apoptosis of the excessive fibroblast, apoptosis of other inflammatory cells, and they will remove from the scene, and the attempt will be made to bring the tissue to as normal as possible. But when there's a flow of aqueous there, these things do not happen naturally, and the whole process gets delayed. So what happens is ultimately there's an exaggerated physiological response. There's a dysregulation of inflammation, extracellular matrix formation, excessive fibrosis, mechanical stress, and ultimately it all builds up into laser. And we have actually now there's enough evidence to suggest that the passage of fluid itself is significant to induce fluid-related stress and cause thickening of the capsule in these eyes. So even if there's a less inflammation and other things are normal, if there's a lot of fluids, that can in some patients induce excessive fibrosis by itself. So having understood a little bit of the pathophysiology, important thing is to identify and rescue identify the blebs which are at risk. Now, objective of glaucoma surgery is basically to have a diffuse functioning bleb, and which should cause lower IOP, and typically they should look like this, a diffuse normal bleb, but reality is that we see very, very different kind of blebs. Now these are the two eyes which operated on the same day by the same surgeon with the same technique, and this is on day 2 post-operative. Can you guess which eye will be both, which eye would be better than the other, or both will the same, A or B? Can you have a quick hand? Who thinks the A is better, or B is better, or both are the same? So here both kind of look the same. You can't really make out which eye is going to behave in better way. This is after 7 days. So after 7 days, you can see, you have to continue the timing, please. Okay. So after 7 days, what you see is that in the A eye, there's some vascularization in the section area. There's some evidence of fibrosis there. Some evidence of fibrosis there, and you can see the vessels are there. But in the B side, B is still not much vascularization. It looks diffuse and pale. So at this stage, which eye you think is better, A or B? A or B? A? B. Okay, so B looks better. Now this is because we are kind of taught that thin, diffuse, avascular bleb are the good blebs, right? This is what is happening after 14 days. So again, after 14 days, you can see there's a good amount of vascularization in the right eye. You can see there's a fibrosis in the wound area. This was a limbal base flap. Some vessels are there, and B eye is still not showing much vascularization, still diffuse, but the bleb is elevated. It has become a little out of focus because the bleb is elevated. Now, what do you think? Is A is going to succeed or B is going to succeed? Any? Who is for A? So B is going to, so you still feel B is going to succeed. Okay, this is what happens 8 weeks down the line. So B becomes an cyst, and A becomes a beautiful bleb which is controlling the pressure 12 millimeters of mercury. So why this happens is because we are taught that a diffuse avascular bleb is a good bleb, but actually it is not so. Now I'll go back to these pictures. This is very important to understand, because we see that the vascularization is a bad thing, fibrosis is a bad thing, but we have to understand that these are the part of the normal healing process. Now in this, what is happening is that these vessels which are there in the A eye, they are superficial vessels, number one. They are very distinct, right? And they are radially arranged. So they mimic normal conjunctival vessels. So what is happening here is there's an attempt to normalization of the conjunctival vasculature. So if you see a picture like this, this means there's a normalization of the conjunctival vasculature. And if the normalization happens, that bleb will not fibrose much, because after that, the scar tissue, as you can see, the scar tissue has actually absorbed. So there's a remodeling has happened because of the apoptosis process. The scar has been removed, and you get a beautiful bleb. But on the other hand, what is happening, if you look more carefully, the vessels are stopping at the incision site. So they are not actually coming to the central area, which remains avascular. Now the central area is remaining avascular, means that area remains hypoxic throughout. So if the area is hypoxic, it will continue to produce those cytokines, VEGF and other stuff, and it will continue, it will keep the healing process going on. Now because the central area is now not capable of mounting a normal healing response, it mounts an abnormal healing response. And that is that you get fibrosis around the bleb. It becomes, that's got a wall of ring kind of a thing, and the surgery fails. So what are the indicators of bleb failure? Indicators are like wound leak, that's number one. That's moderate risk of failure. If the bleb is high, anytime the early post-operative it becomes high, it gains in height unexpectedly, there's a moderate risk of failure. If there's an attempt to localization or cyst formation, there's an attempt for failure. Tendon-cyst formation, increased bleb vascularity. So I'll tell you there's a difference in the good vascularity and the bad vascularity. And if there's a reduced bleb area, again, there's a risk for failure. And if the bleb in the IOP is high, now this IOP is high, sometimes we deliberately keep the IOP high in the first few days by tightening the suture so that your AC becomes more stable early. But after you have, that phase is over, and after you have removed suture or formed the bleb, in spite of that, if the IOP remains high, that's a strong indicator for failure. So this is kind of a bleb leaks. Now this eye, you can see sometimes the bleb leaks are very subtle, and this conjunctiva was very thin, and there is a needle track actually which is leaking. So it's better to deal with them as soon as possible. So if you see a bleb leak, do whatever method, but it should be dealt with as soon as possible. So we went ahead and we actually sutured the bleb, and in the last lower picture you can see the area where we put additional suture, there is a bit of scar there, but the rest of the bleb has survived and the IOP is good. Now this patient again early post-operative phase, and as you can see on the floor scene on the there is kind of diffusely leaking. Now this bleb has a very leak, but it's kind of a limbus because this is a limbal phonics-based flap, so sometimes they tend to limbus. So because this is close to the limbus, we could try a contact lens there. We put a contact lens there, and which gave tamponade. So we kept this for 4 weeks. You keep monitoring and keep it for a longer time, and this is what happens after 4 weeks. We remove the contact lens, and you have a nice bleb there. The high blebs. Now, if you get a bleb localization, now you can see there's an attempt at, the bleb height is getting and the bleb is getting localized. Now, if you see this kind of picture, these blebs are going to become tenocysts later on. So here, the important thing is to reduce the IOP. That's number one. Number two, you massage these blebs to make them diffuse. So try to break the adhesions. Use aqueous in the bleb, as a instrument to do, to tissue dissection around the bleb, and so they will need a lot of kind of a physiotherapy sort of thing for the bleb in the next couple of weeks, so that you can salvage these blebs. And also you have to give the anti-inflammatory therapy. And this is what I mean by bleb, because what you see, I'm squeezing that bleb and pushing the aqueous out from that area. So there are some adhesions here which are broken adhesions, and once you can achieve that, as long as you achieve that, the chances that this bleb is going to survive. But if you can't achieve that, then there will be a problem. Now, this is the differences in the vascularity. So what is the good kind of vascularity and what's the bad kind of a vascularity? I think that we have to understand. Now, this is example I have already shown you. So these are distinct vessels, radial. In between the vessels, the areas look healthy, good. But this is a kind of a bad vascularization. What is happening here is they are angry looking, they are more red, they're kind of dark red in color. They're crisscross, they're not radial, they're crisscross, and they're deeper vessels. So if you have a radial superficial vessels, it doesn't matter how many are there, they are going to eventually absorb. But if you get angry vessels which are crisscross, which indicates a deeper vascularization, those are the vessels which are going to create trouble later on. So here you can remove all the foreign bodies, give steroids, keep IOP low. You may give 5-fluorouracil to stop to halt the process, and it might work. And then if you see a reduction in the bleb area. So here what has happened is the bleb area was something like this, and over a period of time the vessels are slowly growing towards. This is again happening because the central area is ischemic. So it continues to produce VEGF other cytokines, and the process continues until the whole thing is obliterated and you get bleb failure. So in summary, early recognition of bleb failure is important, and the aim is to stabilize AC as soon as possible, attend post-operative complications if any, and bleb appearance, extent and height, vascularity, IOP leaks, and they should be dealt with as soon as possible. And if you do these measures, you can make your bleb survive longer. So thank you very much for this part. And in the second part, now we'll discuss what to do if the bleb is actually finally it fails. So for that, I think we'll have the next topic. Please, I think Dr. Fazal next. You're doing so. If the bleb is failed, I think the easiest thing to do is basically try to do needling of the bleb and establish the blockage which has happened. So Dr. Fazal, I think, will deal with that.
So very good morning. So sir has elaborately discussed about various risk factors and pathophysiology of trabeculectomy failures. Slides, please. Yeah. So we know that despite even with best and even with use of anti-metabolite, the 5-year success rate is still around 50 to 60% of the cases. And the most common cause for the bleb failure is the subconjunctival fibrosis And in significant cases, there is a tenon cyst formations are already discussed. So these are the main two causes. One is a subconjunctival fibrosis and other is the tenon cyst formation. So what are the treatment options? You can either reintroduce the medication, which has again the problem of compliance, adverse events and adherence and financial issues, or refiltration surgeries, which have, because the blood has failed, now the resurgery has more occurrence, more failure rate. So needling means is designed to rebuild the failing blood with minimal tissue trauma. It intended to aim to dissect the scar tissue, that means adhesion between the conjunctiva and the sclera. And this reopened the filtering site and restore the flow of aqueous through the pre-existing sclerostomy into the subconjunctival phase, resulting in a lowering of the IOP. So you can augment the needling with either 5FU or mitomycin C to prevent further fibrosis, and hence you can improve the success rate. I will be, the prerequisite for the needling is there is a patent sclerostomy. One should reassess the causes of risk factor for the failure and the duration of the failure happened. That means whether it has an early postoperative failure or like a delayed postoperative failure. So first I will be showing the procedure. I will be showing this, one is the SILTAM procedure. This video I've taken from Sushmita Kaushik madam due to last moment due to some technical issues. And thanks madam for this video. So this is, you can see, this is a beautiful tenon cyst formation, that is ring of steel formation, 360 degree. There's a large elevated blood which is not draining peripherally. So all the fluid is accumulating within the cyst, and finally that's due to high IOP. So what you can do, you can disrupt the wall, that means the side wall of the ring of steel or tenon cyst. You can use a 26 gauge needle and go subtenon space, and from the periphery advance into the blood and just wall off or cut the tenon cyst wall. And you can manipulate the blood in between. You can press the blood. Now you can see the blood has started forming diffusely or spreading out once you dissect the tenon cyst wall. So you can do like start from the periphery, you can extend more superiorly as much you can, as much possible. Yeah, this is a office SILTAM procedure. Then you just press the blood tissue so that you get a good nice spread out of the fluid towards more periphery. After that you can give 5-fluorouracil to reduce the postoperative fibrosis. 5FU should not be given into the blood, and usually I usually dilute the 5FU, 5 unit to 5FU. I usually make like 15 unit to 20 units. So now you can, after just dissecting the fibrous tissue, the blood clot has came into the anterior chamber. That means your subtenon subscleral area and the sclerostomy is still open. That's patent. So now you can give 5FU injection. It's more in different. You should care that it should not be subtenon space. It's always like more superficial and peripherally, so that it won't be go into the blood and it should not leak into the anterior chamber. That's. So this is another case. There is a delayed subconjunctival fibrosis. This is more of a subconjunctival fibrosis. The fibrosis is mainly around the scleral flap area, not at the periphery. The peripheral conjunctiva was good and mobile conjunctiva. So this is an OR procedure. So under topical anesthesia, put needle 26 gauge needle into subtenon space, inject BSS fluid, and just move this, spread out this fluid into this scleral flap area. This is a kind of a hydro dissection, so that by this gentle manipulation itself, you can break the adhesions between the sclera and subconjunctival subconjunctival tissue. After that, now this area is still remaining. This area is still adhered. So that I used a 26 gauge needle under the subtenon space. Now I need just dissect this area, the area near the scleral flap, this area only. The peripheral area is already separated from the underlying sclera. Yeah, now you can see the fluid is started, the fluid is coming out, and there's more diffused blood, and there is minimal hyphema that even without going into the subscleral space. So you just need to break the adhesion between the subconjunctiva and the sclera. So what are the complications? As we know, this is subconjunctival hemorrhage, hyphema, punctate epithelopathy, more likely due to toxicity of 5-fluorouracil. Buttonhole can happen, hypotony, choroidal detachment, and cataract development. So one can suture the needle entry site if it is so large. Sometimes I used to suture with 80 very absorbable sutures. Sometimes you can leave as like that only. So what are the outcome reported? The success rate of needling with MMC is like 60 to 70% of, and with 5F is like slightly less, I think it is 30 to 65%. Various studies have different type of success because different type of testing criteria for success rate. Overall, the 3-year success rate was like few studies show, Indian studies shows that the complete success was around 31%, and some other additional drug which was more 40%. Some people are used like needling procedure to augment like shunt surgeries like express shunt or Zen gel shunt procedures. This can be in an OR procedure. So to summarize, significant number of trap fails even with antimetabolite. Subconjunctival fibrosis is the most common cause for failure, and needling is minimally invasive procedure and useful in early or late failure. Can be performed as an office or OR procedure. Reported success rate is around 35 to 70%. Thank you. That's
So when can you do needling? I mean, how soon or for how much time interval? Yeah.
because the first few, there's a tenone cyst formation usually happened very early, maybe after 2 weeks itself. Maybe even early as I've seen, even early as 2 weeks. That time you can do a sit-line procedure, but for late, you can't at any point of time because we have seen after 5 years after primary surgery, the main reason is for subconjunctival fibrosis. We usually always try a needling before going to revision or a tube surgery. We always try a needling. Yeah. Yeah, you any
I think needling, some people recommend it early as soon as see the blood is failing. But my preference is actually to make the eye as quiet as possible before you intervene for the second time. And if the eye is very active, is vascularized, and you do needling, there's going to be hyphema, there'll be hemorrhage, and that will again induce fibrosis in that area. So my personal preference is to delay it, control IOP with other drugs, maybe systemic therapy, let the eye quieten down, and then you do needling. So I would like to do it after 6 weeks or longer, and sometime when the blood has been functioning for a number of years and it fails for some reason, needling even works there. So we do even delayed needling also. So your timeline, basically you ask that how much time after the initial surgery you could do needling. You can do any time. Yeah. I think is always a good idea to get consent signed. Yeah, because all these procedures, they look small, but sometimes they can have problems. Yes, you should have consent here. Absolutely. No, I think that would be like you have to explain to the patient there is a procedure and what are the possible benefits, or what what is the expected outcome. Yeah. Because sometime after needling blood shallow, there may be a shallowing of the anterior chamber, there may be a reduction in vision. The patient will get panicky. Yeah, absolutely. Yes. In the original concept that you might need repeat procedures. Absolutely. Thank you for that. I think we'll go to the next talk, Dr. Sushmita. So, internal bleb revision. So, sometime we can actually do from inside of the eye also for the failed bleb. So, I think Dr. Sushmita is going to talk us through that.
And good morning. And at the outset, I thank Professor Pandav for the opportunity to be a part of this. So we'll be talking of something which is ab interno, akin to needling, which Faisal just showed us, except that we go from inside. And ab interno is the flavor of the season for glaucoma. So needling and revision is also there. So failed trab with high IOP, the options, of course, are needling, bleb revision, which could be ab externo, but it could be ab interno as well. Of course, you could do an additional trabeculectomy, a drainage device, or cyclophotocoagulation. So you'd like to revise something which has been done first before going into a second surgery. How do we decide? So we found a couple of years ago, we did a thesis, and it was a clinical utility of the UBM to assess the likelihood of needle revision success. And the question was, why is it that some needlings work and why is it that others fail? And is there some way to predict which is the one which is likely to work and spare them the trauma of needling done? And when we started doing UBMs of the blebs, we realized that there was some in which you could see the fluid right up till there, but it was all scarred subtenons. And there was some in which you could not see that at all. So we termed these a scleral root patent or a scleral root occluded. And intuitively, it's common sense that if you have an occluded scleral root, then simply doing a needling in the subtenon space is not going to work because fluid is not going to go out. Whereas if the block is beyond the subscleral space, so if you have a subscleral or a scleral root patent, those are the ones where needling would work. So we published this a couple of years ago and used this pretty routinely. And the SRO blebs were always likely to need a revision with lifting of the scarred bleb, but the scleral root patent ones, and you can see that's the one that is patent here, once you just do a subtenons needling, you have fluid under the subtenon space as well. And whereas the SRO bleb, nothing much happened. So this was an occluded and nothing much happened even after the needling, and we had to do a revision. So coming on to that, then ab interno revision is recently described. It's the external is more invasive and requires conjunctival dissection, whereas here it's less invasive, it's more controlled, and it's a little more predictable. So it's come up. There is a novel Grover Feldman spatula. It's available. It's a nice curved spatula. It's long. It's at least 15 millimeters because you need to go across the eye, across the bleb, and then do an ab interno needling. The distal end is about 20 millimeters and 0.5 millimeters wide, and the tip is flat, it's blunted, it's anteriorly beveled, and it allows blunt scar tissue dissection without being sharp. So you're not likely to go through the conjunctiva if you're careful and you're controlled. So the principle of the technique is first a gonioscopy. You need to have an open sclerostomy. That's pretty obvious because this is going to go through this sclerostomy under the scleral flap and is going to open up the bleb. That's the idea. So what we do is principally an inferior conjunctival paracentesis, put in a bit of viscoelastic, insert the GFS spatula into the sclerostomy site under direct visualization of a gonio lens. And you can see here it is inside the sclerostomy. And once it's in, then you remove your gonioscope and then you move it side to side. So there's a small clip which I'll show, a representative case of a 54-year-old POAG, failed trab, scarred bleb, patent sclerostomy. Typical patient to do. Now we don't do the UBM and figure out which to do a needle revision. We just use the spatula, do an ab interno, do not open up the conjunctiva or poke in any needles, no more dissection of the blood vessels and all that, and we just do an ab interno. So this is what it looks like. So this is what the spatula is. It's 20 millimeters, and this is the tip. So this is topical anesthesia. If they're not too cooperative, you can give a block as well, but this was a nice cooperative person. I like to use pilocarpine to protect the lens as much as possible, even though it's pseudophakic. So as usual, a cohesive viscoelastic on the surface of the eye. And this is an indirect gonio lens. You can't use a direct lens because you can't tilt the head upwards. So we use an indirect. So we go across, and there you are, the indirect gonio lens. So it's a little bit of a learn to put your spatula into the sclerostomy with an indirect gonio lens, because you're working against what you're seeing and it's a mirror image. But once you're in the sclerostomy, you can see that it's entered. You can remove the gonio lens and then go on, and then it's really simple. So this is the only tricky part, to get your spatula into the sclerostomy. And once it's in, then that's it. Then we just gently use a bud, and you can see this gentle to and fro movements, and this we are under the scleral flap. And in a little while, you'll see that we have traversed the scleral flap and we've actually gone into the subconjunctival space as well. And that's what happens when you see the blue tip of the cannula. You see the blue tip there? There you are. So you can now start seeing the blue tip of the, here you are. Can you see this under the subconjunctival space? So now you're under that as well. So you've traversed the subscleral space, you've gone into the subconjunctival space now, and gently, and you can see there's no bleeding because it's completely blunt, but it's gentle, and there you are. So there is the tip of the thing seen, which tells me that I've traversed the subscleral flap, I've gone, and once you're in the subconjunctival space, then it's easy, then you get a little more. So the important thing is to go straight up there and not go side by until you reach the subconjunctival space, and then when you've opened it up, then you can sweep across really, and you can open up this bleb nicely. So I'll just show you the end, which is, where is it? Yeah, so at the end, all you need to do is when you remove it, we just hydrate it, and when we hydrate it, you'll actually see the bleb forming quite well. I don't know why this isn't moving. ये video नहीं चल रहा suddenly भैया. It just shut. It's hung. Okay. क्या करूँ? Close. नहीं, hang हो गया. Close. I'm so sorry. I just wanted to show you that at the end, all you need to do is hydrate it, and the bleb just forms when it hydrates, and then you know that you're probably in. We didn't, I mean, by the time you just do that, it just keeps coming out. You can. हाँ, ये था वीडियो. इसका end दिखा दो बस. वो ना बीच में बंद हो गया अपने आप. I don't know why. End कर दो. हाँ, ये. Yeah. So there is a bit of bleeding there. So I just wanted to show that sometimes happens because it is sort of blind. But then you put in an air bubble, and next morning usually nothing happens and it's fine. So this is what he looks like. So this was absolutely flat, and here's all the fluid there. It's 18 millimeters he was pre-op, and post-op day 7 he's about 7 mm off drugs. And we sort of, over 6 months time, he looked very good, and this is what the blebs remain as. So we're quite surprised that this actually happened. So we looked at them. We use the AIOC as well now. You can actually see, now this is just a gimmick. You might as well do your gonioscopy and see the sclerostomy. This is just to show that you can use a sweat source AIOC to show you your sclerostomy. So that's the sclerostomy of this bleb. And you can see this bleb, it's completely occluded, and no amount of needling is going to open this up. So this is a classical bleb in which I'd like to do an ab interno. And when we did that, you can see this has opened up. So this opens up the scleral flap from beneath it, and there's fluid under the, so this is this bleb which becomes this with all this fluid which is under the scleral flap as well as the tenons. So this is now much easier than doing a UBM since we've acquired the cassia, and we're lucky. So the early experience is encouraging. Quickly, I'll share that in the next minute or so. We looked at patients with a minimum of 6 months follow-up, but some of them have a year's follow-up. It's about 15 eyes now. And the mean age was all around 60 years. And the mean age of the bleb was about 5 years, but they range from 6 months to 17 years. And so the complete success of less than 18 millimeters without drugs was about 40%, but 60% with up to 2 topical medications. So if 2/3 of our patients can do without an ab externo, needling, revision, second surgeries, for me that's good. And the failures we had was 0, which was good. Nobody had hypotony, nobody had serious complications warranting any other surgery. These are the graphs of the IOP change, but more importantly, the anti-glaucoma medication change. So from 3 drugs or 3.7 drugs, which is almost 4 drugs, down to 1 drug or so, for me that was good. So if you can just get back to that. We had transient hyphemas, of course you see it on table. We had 1 shallow anterior chamber and 1 conjunctival buttonhole and microleak, while we were still learning not to be so aggressive. So now we don't see them too well. So thank you. It's something that's worth exploring, and we're very happy with the results and hope we come out with 1 year and 2 year follow-up soon. Thank you.
Thank you, Dr. Sushmita. I think before I go to my presentation next, I think just a quick question. How do you kind of choose which, bleb would be needled externally and which bleb would be needled internally?
So frankly, sir, I've stopped the needling externally because this is so much easier to just take them into the OR. But definitely on the ASOCT, if there is a good scleral root patent, then you might have a case for doing a subtenon's needling. But this is lesser invasive than a subtenon's needling also, because we do go into, and it's easier if it's not fibrosed, then it just goes straight into the subtenon space, and it's easier to do it from inside.
Thank you. Third. So I think after that, I'll introduce another procedure. That's the limited posterior revision of the bleb. Sometimes what happens is that whatever you have done, your bleb gets actually scarred, and you might have done a few needlings, and still it scars. Sometimes the fibrosis is so much and the bleb is so tethered inside that you are not left with any other option other than can I have the presentation, please? Other than basically doing a fresh surgery, perhaps all look for some other alternative. Yeah, you can give me the presentation mode, please. Yeah, thank you. So in that case, what we do is, so we know the failures of trabeculectomy are common, and we have looked at some options. Bleb revision can also be done, and bleb revision could be a full revision of the bleb, fresh trabeculectomy, and there are already some publications where excision of the thick scar can be done, or it can be done with a needle, or even a laser has been tried, but with a variable success rate. So the needling basically works best when there's a fluid pocket under the Taylor's capsule. So if that means the communication with the anterior chamber and the space outside has to be there, only then the needling will work. So if it is a bleb is totally flat, if there is no communication to the outside, then I think the internal revision would be a better option. And if there's no fluid pocket, or there's a fluid pocket with extensive scarring around it, then these procedures, they don't do very well. And in that case, you might have to look for a full revision of the TAD. That means you excise that tissue and kind of refashion the whole thing, or do a different trabeculectomy at a different site, or you consider the use of a glaucoma drainage device. Where nowadays, the threshold for using drainage devices is actually low. So if you have a one trab with MMC failed, I think you start thinking in terms of a drainage device. So I'll talk about a limited surgical excision. So this is kind of a typical scenario. You have the bleb which is kind of a closed, the whole thing is fibrosed. There's no passage there, painted there, and you can see there's a lot of scarring in that area. So what we can do is that we can do a incision through a bleb revision through an external keyhole incision. So you make a smaller incision, and then you can do a revision through that. The procedure, basically you have to do it under anesthesia, and so you will need some kind of a traction into the basically need to rotate the globe downwards and make a 2 to 3 millimeters conjunctival incision, a little 7 to 8 millimeters from the on the limbus. So this is a kind of diagrammatic representation. So you're going beyond the scar tissue and making an incision there. And through this incision, you will dissect. And once you are dissected, the conjunctiva, you can use the advantage here is that you can actually use this, mitomycin C or some other chemotherapeutic adjunct you want to use, and then you pass the scissors under the conjunctiva and keep dissecting bluntly. Most of the time you need a blunt dissection, and once you have gone under the flap, you have to identify the flap, go under it, and the fluid will come throughout this area. You can actually create a bleb more posteriorly with minimal dissection. So this I'll show you with a video. I think that should be more clear. So basically, so this is the old bleb which is scarred, and there's no fluid, there's more of a scar tissue there. So you go beyond this bleb and make a small incision, about 2 to 3 millimeters to begin with, and go go deep to the. So you have to identify the sclera there. So cut all the scar tissue, identify the episcleral plane. So your plane identification of the plane is very important. And then in that, once you have found the subtendon space, you kind of create a pocket on both the sides. And now idea is basically to now we are so we are not touching this area as of now. We're just creating an alternative place where the fluid can be drained. So make sure that you have a nice space there. And once that is done, you can put so this is somewhere around 8 or 7 or 8 millimeters from the limbus, and then you can put mitomycin sponge like you do for routine trabeculectomy. And you can put 2 or 3 pieces of sponge soaked in mitomycin, 0.2 milligram% for 2 minutes. That's the usual dose we use. And once you have exposed this area to mitomycin for you have to remove the sponges and make it's good to have access to the anterior chamber. So have a paracentral some side port available in case you need to inject into anything in the anterior chamber, and also that will help you confirm the patency of the passage later on. So now I'm dissecting under the scar tissue basically. So you may be able to identify the scleral flap, but I think you just keep bluntly. So C is all blunt dissection, and at some point of time the aqueous starts coming, because you're lifting the scar tissue up from the scleral plane, and you can see the fluid is coming. So inject the fluid and you could see the fluid coming through that area. So that kind of confirms the patency, and that's basically end of the procedure. Now you just close this. You're not using any suture to the flap or anything. Just leave that patent, and because it's small incision, so it can be easily closed with 8-0 or any other suture. And that's the end of the surgery. Now sometime it may happen that your AC becomes shallow or flat, so make sure that you inject BSS into the AC and it will form. And if still very shallow, sometimes there may be overfiltration. In that case you can leave some BSS, some viscoelastic in the anterior chamber to keep the bleb there. And this is what the post-operative, the same eye, actually you can see there's a nice bleb there where there was a scar tissue earlier. And this is another eye, showing nice bleb after the surgery, and another eye, something similar procedure. So prerequisite for the procedure, basically the previous site of surgery should be able to identifiable. There should be good conjunctiva in the adjacent of the scarred bleb. Gonioscopically iodectomy should be patent, and also the trabeculectomy site should be identified and should be patent. The fistula should be patent, and of course you have to take consent for the surgery. The contraindications will be if you can't identify the previous surgery, if there's stapholoma, if there's extensive conjunctival scarring, thick synechiae in that area, blocked or absent iodectomy. Trabeculectomy site, if it's not visible or identifiable, you could do that. So this is a little bit of our early experience, first 44 eyes where we actually did procedure, and you can see the variety we have used for a variety of glaucoma, primary as well as secondary glaucomas. And you can see the IOP controls. IOP control from 20 plus with all the drugs, it comes down to somewhere around 12 to 15 milligrams of mercury with very less number of drugs. So there's a marked reduction in the number of drugs that we are using, and this data is actually over 4 almost 3 years. So we have been doing this procedure for a long time, and I think the results appear to be quite okay. So there's a good amount of success rate, I would say. If you look at the complete and qualified success, at least in 6 months, is to the tune of almost 85-90%, which is pretty good. So to conclude, bleb revision through keyhole conjunctival incision is a viable option for some of these failed blebs. Thank you very much for your attention, and if you have any questions, we'll be happy to answer. Yeah, we can do, because all these eyes actually had undergone. We have done this procedure in our own operated eyes, which have failed earlier, our own cases. The reason that we know what we have done, there is some documentation. We know what kind of flap we make and how to deal with it. But if on clinically you are sure about the site and in the flap, other things, you can do it in other cases also. But we do use mitomycin C because they are kind of high risk eyes for failure. They've already failed, so it's better to use mitomycin C and drain this. Basically what we are doing is we are draining creating another drainage site adjacent to the previously operated bleb, so that fluid can get into that and can be drained from there. GDD is actually difficult because there's a very thick fibrous tissue. Yeah, people have tried. We have also tried needling and even with mitomycin C, but I think GDD needling doesn't work that well. I think the trabeculectomy needling works much better. And also in GDD, there's a thick capsules. We have excised the whole capsule, a few times, that you can do in a valve device. So it's easier to do because there's no risk of hypotony. So you can just go in, cut off the entire tissue, the capsule. But invariably it comes back again, it forms again. So even with mitomycin C, it forms again. So I think the fibroblasts in the anterior part, in the palpebral conjunctiva and in the tenons area, they behave a little differently, and they're also not very amenable to mitomycin C application. So I think GDD blebs, they don't behave that well after needling or after excision. People have used basically a lot of strategies to reduce inflammation, but there's no distinctive advantage of role of cyclosporins as such.
Conjunctival fibrosis or subscleral?
It is basically subscleral, yeah, because there's a tenon capsule there, and which is injured, so from there the fibrosis is happening. But even if you remove tenon's capsule, the fibrous tissue still grows in there. Yeah. Sorry, sir. Injection or sponge. I think both have been used, but the advantage with the injection is that your dose is much more standardized. So we are using that in our institution. But I use the injection. I'm still like with the old. You're also on sponge now, so I'm with basically on the old technique, because we are so used to it. But if you look from standardization point of view, the injection definitely, you know how much dose you have injected. We have injected. So I haven't used the injection much, but I don't think there's any difference. But it's a low dose. It's a very low dose actually. 0.0, 1 milligram percent or something is a very low dose. I haven't used it frankly, but I am still on the sponge, which I find very easy to where to apply it and how long to apply it. So I can titrate, but how much is actually going into the tissue, we don't know. How much is being retained, we don't know. But that's the kind of standard procedure has been for many years. So yes. Can we have the mic, please? Because
Which viscoelastic material you recommend for reconstruction of the anterior chamber?
Yeah, we would like to use the viscodispersive one, like methyl cellulose.
Methyl cellulose.
Methyl cellulose.
But what about the viscot?
I don't use Scott because this is a little difficult to take out of the eye, and it moves like in a bolus. So you might suddenly, if it goes out of the trabecular site, it may go out of as a bolus suddenly, and then it would collapse. But in the first place, it will be little harder to push. But the viscoelastic, the dispersive type, because it kind of mixes with the aqueous over a period of time and is more gradually reduced. And so I prefer a dispersive.
So far the inflammatory status concerned, is it viscot not superior than methyl cellulose? What is your opinion?
From cataract surgery point of view, definitely, but here the
inflammation point of view. Inflammation, post-inflammation
point of view. Yeah, I think there could be some. I don't know practically there's any difference in the two.
Thank you.
Yeah. Any other questions? So I think we have a keynote address. So I think I'll invite Dr. Rajesh Kumar for his keynote address. And if we have time after that, you can still ask some more questions.
Thank you, everyone, for this opportunity. Thank you, Dr. Pandav, for the introduction. So I have been asked to talk about different angle to managing acute angle closure. What are the different modalities that could be possible? No financial disclosures. Now, we all know that angle closure disease is a spectrum going from angle closure suspect all the way to angle closure glaucoma, which can be initially medically controlled and then remains uncontrolled and causes more progression. And at all these spectrum of the disease, we can encounter acute angle closure. Now, if it remains on this in the spectrum where there is no acute angle closure, the morbidity is slightly different than when there is acute angle closure as an event happening. Now, etiology for angle closure disease, of course, pupillary block, angle anomalies, lens factors, and behind the lens factors. So why discuss this? Because acute angle closure can cause significant morbidity over time. In about 60% of people, people require medications within 5 years, and about 35% eventually require trabeculectomy. The idea is to prevent visual loss from high pressure episode that can happen, and also to prevent progression to angle closure glaucoma if that's not already been present. And over a 4 to 10 year period post acute angle closure, data shows that 18% of patients can go blind, about 50% will have significant glaucomatous optic neuropathy, and about 60% have a fall in vision as well. So the principles of treatment are to primarily reduce pressure as quickly as possible, to reduce the inflammation, and also to reverse the pupil block and open the angle as much as we can. The goals of treatment are also to prevent risk of damage to the anterior segment, reduce risk of optic nerve head damage, and also to prevent recurrent spikes in pressure. So lowering the IOP will reduce the corneal edema. There's a conventional medical method and laser iridotomy, whereas there are alternative methods like anterior chamber paracentesis, ALPI or pupilloplasty, corneal indentation, supine positioning, and corneal scraping, which have been tried to a certain extent. Now, IOP reduction is done medically with our known entities, and this will allow us some corneal clarity, and then eventually that is followed by laser iridotomy. And always remember, we've seen so many patients who come in with the acute angle closure eye having had laser iridotomy, and the practitioner has not done laser iridotomy in the fellow eye. This is literally a crime, because about 50% of people who have acute angle closure in one eye can have, the risk is like almost doubled in the other eye. And it's important to remember always to treat the fellow eye as at some point and not forget about that eye till that eye gets an acute attack. Now, like I mentioned, various methods have been tried, So studies have shown the reversal of acute angle closure episode within the first 24 hours happens in almost 90% of patients, and about 22% over 3 hours, and about 50% at 6 hours, and about 80% in about 12 hours. Complications and side effects are relatively low. In about 2.2% patients, it fails to resolve and requires surgery at some point. Now, laser iridotomy remains the treatment of choice at this point in time. It's relatively non-invasive, easy to perform, low risk of complications. There are a few issues like bleeding and hyphema in an inflamed iris. Some IOP spike post laser, the LPI might close soon after that, and there can be rarely corneal decomposition that was reported earlier but not seen anymore, because I think we have become more sort of attuned to using the right amount of laser power and the right techniques. Now, methods and effectiveness can vary by race, and in non-pigmented irides, the YAG capsulotomy alone may work better, whereas in pigmented sequential argon YAG capsulotomy, iridotomy may be a better approach, where we actually trench the iris first with argon laser and then use YAG to open up the trenched part of the iris. Now, Caucasian eyes, LPI alone seems to be sufficient in controlling intraocular pressure in about 70% of patients. And additional medical therapy can control patient IOP in about 84 to 99% of patients. Whereas in Asian eyes, LPI alone manages to control pressure in about 35%, and about 60% require use of additional IOP medications over time, or even glaucoma surgery. Now, relieving pupillary block, LPI is the best and the best approach. And if you look at data, they've shown that about 60% eventually need drops, and about 35% require surgery at some point. And a smaller study showed that about 100% ended up requiring drops over 63 months, and about 60% required surgery. Now, corneal edema and poor visibility could be a challenge when you have laser iridotomy in an acute angle closure eye. Bunched up iris can cause poor penetration and bleeding. There's more pigment dispersion, of course. Patients can be poorly cooperative due to all the systemic conditions, pain that he's suffering, and couple of sittings might be required. Now, the problems with medical management, of course, there are systemic contraindications patients may have to medications, also risk of systemic complications with the medications in the form of metabolic acidosis, electrolyte disorders, and congestive cardiac failure if patients can be contraindicated and can't use mannitol if at all. And there are eyes that are refractive to this as well. So some angles open up after laser iridotomy, some don't. And there are multiple reasons for it. So if we can't, what are the other alternatives? Iridoplasty and AC paracentesis have been tried, and then further going on to lens extraction and goniosynovial or trabeculectomy. Now, ALPI or argon laser iridoplasty causes contraction burns to the peripheral iris, and this sort of pulls the iris away from the pupillary area and allows us to reduce pressure. Now, it allows good IOP control initially, good reduction in intraocular pressure in eyes which are sort of not amenable to laser iridotomy on the table, and allows to sort of reduce PAS in some to a certain extent. And versus medical management, however, no long-term significant differences were noted. And there are issues with efficiency which is lesser when there's already pre-existing PAS, and there's also a learning curve, and it's also again tricky in cloudy cornea. Now, typically indicated when corneal edema persists or anterior chamber is very shallow to allow a safe iridotomy, and this pulls as I mentioned, pulls the angle open away, facilitating some aqueous drainage. Now, in about 70 eyes, I would attempted to do acute angle closure, initial treatment with timolol, pilocarpine, randomized to iridoplasty versus medications, no significant difference in mean IOP or need for medications or extent of PS between the two techniques. It is a safe and effective alternative in medical management of acute angle closure. If you look at the cons, like I mentioned, you can have corneal abrasions and corneal endothelial cell damage because of the fact that sometimes the ACs are so shallow. Persistent mydriasis can be a challenge in some patients, peaked pupil, and it technically does not eliminate pupillary block because you're actually treating one small segment of it. Anterior chamber paracentesis conceptually evolved as a path to sudden reduction, rapid reduction in intraocular pressure, similar to indications as iridoplasty, and if there is lack of access to immediate laser therapy, and controlled range of aqueous from anterior chamber by needle or 15-degree blade. Now, technically challenging, AC shallow can cause trauma, it can cause bleeding, and rapid decompression can cause suprachoroidal hemorrhage and retinopathy and hyphema, aqueous misdirection in rare instances, and the risks that are inherent to any intraocular procedure. So it showed that IOP started to rise 2 hours to levels that were comparable to medical treatment soon after patients were subjected to paracentesis. However, I think in the literature for this approach is limited, and the benefits of paracentesis appear very short-lived. It's an invasive technique. Asepsis is always a challenge. Patient cooperation is important, and you need to follow it up with the laser iridotomy as early as possible or attempted. And potential risks of infection, decompression remains a concern. So pupillar plasty is also another temporizing measure that's been tried. Corneal indentation using muscle hooks or gonio prism or cotton tip applicator or glass rods have been tried. Again, all these are short-lived, immediate relief, but for the corneal edema to be clearing up faster and makes it easier to sort of then perform laser iridotomy at an earlier stage if that's the case. So which angles? So lens also, a large lens can also play a significant role in sort of the final outcomes of acute angle closure. And the benefits of cataract surgery and residual angle closure remains after LPI. The lens extraction allows for relief pupil block, reduces crowding, and widens the drainage angle. Multiple studies have shown significant benefits in cataract extraction versus LPI. However, cataract surgery in acute inflamed eye is challenging. Inflamed eye this can cause and the view is poor due to corneal edema, higher risk of endothelial cell loss, floppy iris, small irregular pupil, and higher risk of intraoperative complications. And there's also a temporal time relation from acute angle closure to surgery. So cost effectiveness may be an important factor to consider. We can also consider synechulisis. Glaucoma synechulisis for effective IOP control has been attempted and has found to be quite effective. Trabeculectomy and trabeculectomy are rarely sort of indicated in some instances and has been shown to have fairly good success. So, however, the role is limited because of the high risk of surgical failure and complications in an inflamed eye and may not be the initial treatment of choice. So, to summarize, medical management followed by LPI still remains the procedure of choice for acute angle closure as the first approach. Iridoplasty lens extraction or alternative methods that can be tried. Synechulisis is a useful adjunct to manage PAS, and filtration surgery if there is clear evidence of extensive synechia with advanced glaucomatous cupping. The cost-benefit ratio and life expectancy also has to be considered when we look at the different approaches to manage acute angle closure. Thank you.
Thank you, sir. So, any comments or any questions you would like to ask Dr. Rajesh? I think Dr. Rajesh, many times, when the acute angle closure, the attack which is of a recent onset, a few hours or maybe a day, that's a little kind of easier to manage. But once you have, is a delayed or it's not recognized early enough and you have a lot of inflammation and other tissue damage occurs. So how can you kind of deal with those situations
I think, irrespective of where we practice, I think access to an ophthalmologist still remains a challenge. And the time of presentation, like you said, from the time the acute attack happens, irrespective, I think all of us will agree that laser iridotomy is not something that has not been achievable in most patients as a first step in management. And, the medical management that preempts that before we do the procedure. It's very rare that we don't manage to succeed with this. The only challenge, of course, is the amount of laser we have to use in some instances if the iris has been inflamed for a while and the bleeding that happens from multiple shots. So you would think that you would try and do a laser at one spot. If it's leaking or bleeding, sometimes it is best that you put pressure with the lens, sometimes even give the patient a break, wait for that to clear up and attempt again, instead of trying to keep on shooting multiple times through the bleeding iris.
Doing laser iridotomy is actually quite difficult once you have the iris is inflamed, and you end up releasing more pigment and increasing inflammation, basically, it could actually make it worse. So, the surgical iodectomy would be better option there.
Yes, it's invasive, so that's something that we'll have to, I mean, if it's that sort of situation, I would think that if there is a cataract, there is a clear opportunity to think about cataract extraction, but definitely not clear lens extraction. I don't think that's there's no evidence for that, at least.
Cataract surgery in the acute phase is actually difficult.
Yes, it's very challenging.
It's challenging and is more prone to have develop complications.
Experience that wouldn't be something you want to attempt.
So do you consider like decongesting these eyes with some IV mannitol?
Yeah. So mannitol, IV Diamox,
yes,
IV
some topical steroids and make the
steroids all help to bring it down effectively.
So if you're successful in reducing the pressure initially, I think that gives you time to plan. Then you can actually wait for a little while, let the eyes settle down. Maybe certain hours or days, and then you could do laser iodectomy.
It might be even worthwhile waiting for. If you break the acute attack medically, it's even worthwhile waiting for a day or two before you do the LPI. It doesn't hurt.
Thank you, Dr. Bhattacharjee, for joining us, and welcome to this session. Yeah, Dr. Bhattacharjee has a question.
I want to know your best recommendation for a type of patients. So one of my patients, he traveled by air and he underwent vitrectomy surgery with C3F8 gas. Now, while the flight took off, after some time he developed severe pain and loss of vision. So when he landed, the doctor over there, of course he did not comply with our advice. So he advised to come back by surface. So 3 days over. The patient came with a intractable pain in the eye, bouts of vomiting, completely flat anterior chamber, there is inflammation, and inflammatory exudates are there in the anterior chamber. What will be your line of management in this type of patients?
So it also depends on whether a patient had silicon oil in the eye.
No, gas, C3F8 gas.
So the silicon oil itself could be causing...
No, not C3F8, no silicon. C3F8 gas.
C3F8, okay. So we have to break the pressure attack in the first place, medically if possible. You obviously can't try and... and you also have to think about why this is sudden flattening of the anterior chamber.
Because of expansion of the gas.
There could be aqueous misdirection, Dr. PANDAV, in an instance like that, there could be aqueous misdirection as well. So I think the key is to look why the event happened and to control the pressure as much as we can initially medically with Diamox and IV Diamox and putting him on Diamox for a few days and finding out if the back of the eye looks stable and see how that breaks the attack. Completely flat AC is very rare. Would you be talking about a grade 3 shallow or like a grade 1 when this
it is almost plastered to the anterior chamber, to the endothelium.
Yeah, but I would think that
could it be due to the overfilling or
it was exactly not overfilling. He
or expansion
went up into the sky. It expanded, and by 3 days the inflammatory exudate caused an adhesion. So what we did in this case, we started the regime that you have advised. The next day the intraocular pressure is still 60 to 70. Then we removed gas from the vitreous cavity, and thereafter the intraocular pressure come down to around 40. The next day we reconstructed the anterior chamber, but still with full medication the intraocular pressure is still maintaining 30. So what you recommend? Will you go ahead for a incisional surgery or a bulb implantation?
So what was the indication for the vitrectomy?
The vitrectomy indication was retinal tear and vitreous hemorrhage.
Okay. So the next question is on gonioscopy, was the angle open after?
No, it is closed.
Completely closed?
Even with the slit lamp, it can be seen the iris is there over there.
Yeah, that's what I think this is happening because the angle is totally closed. So whatever you do, it's not filtering. Basically, there's no echoes going out. Yeah.
While doing the vitrectomy, was the AC formed or not is a question.
Yeah,
And
at that time,
on that stage, did
no,
we
the
do a
patient was in
gonioscopy to check?
completely stable condition, and then the patient was discharged.
No, what I mentioned is when we removed the extra gas on day 2 because the pressures are not coming down, did the AC?
No,
deepen?
AC was not formed. Then
So
we
that is
reconstructed
something-
the AC.
That is something that should have been a sort of the biomarker, if you want to call it that, to before taking the patient off the table to make sure that the AC is well formed, and then figure out otherwise.
So
why it should-
you're suggesting that I think if you when we reduce some of the gas from the
even though PI
vitreous cavity, the AC can be formed. It should be formed. Okay, and that
even
might
though-
restart
even though
the
PI,
that may restart the kind of a exit through the trabecular meshwork and opens up the angle. So unless the angle is opened up, the pressure will remain kind of
because
unpredictable.
obviously
It remain
something's
high.
pushing, right? It's a pushing mechanism more than anything else.
Okay.
Correct. And that's what I said. Aqueous misdirection is
But
the
the
first
gas
thing I
has
would
been
think.
removed.
So taking out the gas alone is not enough.
Yes, I think once there's a gas or silicon oil in the eye, I think you will tend to kind of think that there might be something to do with that, but the volume in the posterior segment. But sometimes, like you are saying, sometimes we do see there's no gas in the eye, there's no silicon in the eye, vitrectomized eye, and that can develop a shallowing AC, high pressure picture, something like aqueous misdirection. Yeah.
Correct. So
Yeah.
it's more
No,
of a core
in
vitrectomy
this
than
case,
vitrectomy.
there is no remnant of the vitreous on the posterior capsule.
Actually, I have seen that. I think what Dr. Bhattacharya is saying, I have seen that once happening. This was a repeat vitrectomy and complete vitrectomy. In fact, it was done for malignant glaucoma itself. So patient had aqueous misdirection, and usual treatment was done, including vitrectomy, didn't resolve. And we did repeat vitrectomy with, make sure that all the, there's no vitreous left in the pars plana area anywhere. And the AC is still shallowed, and there's still secondary angle growth was still there. So eventually that patient had needed a tube implant. But here, because there's a gas in the eye, so we put a tube implant, the gas is going to out. So the
No, the
purpose
gas we have removed now.
have removed.
Then
I think gas is removed, the pressure is still high, then probably you can put a tube in behind the iris. I think if there's no silicone or no gas, then I think that is a little easier situation. But if there's silicone oil in such eye, or if you still need the gas, and then there would be a difficult problem, because sometimes it happens. I mean, iris just lens diaphragm just doesn't go back. Iris just doesn't go
I
back.
think the first thing you think about when AC is so shallow, I think everyone will agree with me that you're looking at an aqueous misdirection. That should be your first sort of diagnosis, and then work backwards from there. How do you break the aqueous misdirection?
Thank
and
you
if there
very
is no
much.
LPI when you're doing the gas, do a
Now,
PI.
PI was not possible because it's only
No,
stucking.
that's what I said. So with the vitrector,
Yes.
you can actually cut and make punch a hole from inside, from back to front. Right?
Yeah, the case I'm referring to, we did the iodectomy with the zonulectomy, we did the hyaloidectomy, rather actually vitrectomy in the first part with all these. It didn't work. I mean, it worked for initially, and again it got shallowed. And then we did complete vitrectomy, and still it came back.
I remember in every Prasad, there was one patient, you did all this, and the patient had to be permanently on atropine, and that wasn't a possibility. So we would stop the atropine, and again it would go back to aqueous misdirection. So finally needed a tube.
Yeah, so I think our patient also ended up with a tube. In that.
Thank you very much.
Thank you.
And any other questions? So we have actually discussed a lot in this session. We talked about the, bleb failures. We have talked about the wound healing, the pathophysiology, how to identify failing blebs, what are the risk factors for that, and how possibly we can, salvage the situation. So if you have any questions related to in these areas, please feel free to ask. We still have a few minutes. So, Sushmita, I think how So your internal, I think, because you are doing mostly the internally, you are revising these blebs. But sometimes I find that, even if you find that the ostium, and pushing it through subsequently is very difficult, because there's a lot of fibrosis already there, and you really have to use a lot of force there. So how do you can you predict pre-operatively that, okay, this is the patient where probably you should not be doing internally?
Yeah. So, sir, actually, internally we do it in the cases where we see a subscleral fibrosis. The idea is to remove it, and I think if we just go slow and dissect up till the conjunctiva, it is possible. Because if the scleral root is patent, then it's easy to do a needling subtenons. Then there's no problem. And now with the AIOCT, we can find that out. But it is the ones in which the scleral is stuck is where we go through this.
Yes, in some of these cases, they have a fistula is patent, and some fluid is actually coming into the subtenon space, and you have a very small localized bleb. So there is a fluid there already.
Yes. But not enough.
Yeah, but not enough.
Not enough.
So are those patients also amenable to this
Yes.
therapy, or they are better treated from external?
Sir, external, I
needling?
think, always lands up in more inflammation because we are cutting, we are, opening it up, we are going in. So I found that without using cutting, without doing anything, just dissecting out seems to work a little better. And maybe I forgot to mention that we always use mitomycin injection a week prior. They've said a week prior. Our logistics makes it about 5 or 6 days prior. But that's something which needs to be done. And 0.01.
So how much do you? I think that also relates to
0.01 for 2 minutes, just subconjunctivally in the phonics. Because we won't be washing it out, and it would all come into the anterior chamber once the pressure is low. So on table, because there's no external tunnel, it's all internal. So there's no place for the MMC to get out. Maybe that's why, and we rub it up with a bud and diffuse it out about a week prior, let it stay there, and then we do it. Do the ab interno.
So are you concerned about any long-term complications? We are leaving mitomycin C there.
Yes, 0.01 we are leaving. Till date, we haven't found anything. Dr. Grover have got out their 3-year results. They haven't found any, maybe because the dose is so small. And maybe we are intervening optimally, actually. The MMC would start in about 5 to 7 days, but we are actually leaving it on table. So maybe at the time of the fibrosis starting, maybe that's why it's working. But touch wood, till now, we haven't had MMC-related complications.
So that means the pressure flow is not working very well at lower doses. Okay. But you need a lot more mitomycin C to make it work. That's what they found from my yeah. I think regarding your viscoelastic, I think the overriding I think issue has been the pressure with me, because that's why I've been using the dispersive type. But I think you have a point there regarding inflammation. That would be safer if you're using some viscoat or something, but I think that tends to give a little more higher spike. So I think that's the reason I've not been using that. But maybe one can try, but I haven't tried that. Thank you very much. I think, yeah, you have a question?
Extremely fragile. In primary trabeculectomy case, how to choose also? If it is extremely fragile.
The conjunctiva? Yeah, I think you have to be careful. Your dissection has to be careful. I think those surgical techniques, so you have to be careful. And in those, yeah, yes, sometimes it happens. They don't use, yeah, yeah. 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 And Yeah, don't use mitomycin C definitely on those cases, so because it'll make it worse. Thank you very much. I think we are at the end of the time, and we have to hand over to the next session. I thank you all, for attending this conference at AIUS, and all the speakers who have participated and done some hard work to explain things to the audience. Thank you all very much for your attendance, and thank you everyone. So we close the session here.